Welcome to Convos from the Couch from Lifestance Health, where each episode you'll hear engaging and informative conversations with leading mental health professionals that will help guide you on your journey to leading a healthier, more fulfilling life. Hello, and welcome to Convos from the Couch by Lifestance Health. I'm Nikki Lienza, and on today's episode, I'll be talking with Melinda Zaponne, a clinician from our Tarrytown, New York office, and we'll be having a great conversation about how therapists are people too. So welcome back, Melinda. Great to have you back on.
Hi, good to be here.
I know
and,
you're
and not here at the same time.
Yeah, that's right. Exactly. I know we had you on before where you had your amazing client share her story with bipolar disorder. We have you back on today to talk about just us therapists, right? And kind of our experiences. And so I know you told us a little bit about you last time you were on, but do you mind sharing a little bit more about yourself?
Yeah, I mean, I'm going to share. It's funny because this is my point is, therapy is ultimately going to be a conversation. It's going to be a relationship, not really like, we think of it as a service. So this is nice that I'm able to do this. I think that I am Auntie Melinda. I'm a sister, I'm a daughter, but really, I mean, I am a therapist. It's very much who I am. I'm somebody who struggled a lot with self-doubt my whole life and has a trauma history and was very disappointed with therapy myself. So, I think that as I become a therapist, it's been at times therapy. And it's been a real eye-opening experience with boundaries and people. And recognizing I'll go buy a car and I'll know everybody's life story by that time I'm done. I am a therapist. So part of who I am is learning about people's life story. But even now, when I go out into the world, I want to do that too. I want to know, as I'm interacting with you, even though we're just buying a car, what is the deeper relationship here that, we can kind of get out of this experience. So I guess if I want to say a little bit about myself, I'm just, I'm a connector. I'm a listener. It's like who I am.
So you definitely sound like you're a therapist through and through, for sure, Melinda. My gosh. So what initially got you interested in becoming a therapist?
So many things. When I look back on it, because you had given me this question, I was trying to think about that. I feel like there's breadcrumbs, I've been leaving breadcrumbs, but following breadcrumbs to this goal of becoming a therapist. I think, like I said before, I had a lot of self-doubt growing up. I was born into a family where it was kind of a pressure to make it a family because my mom had 2 kids before. And so it really became like my birthright to kind of connect to this family, make it an actual family. And then when I was struggling in my own issues in undergrad, I didn't really know I wanted to be a therapist yet, but I was working in a psychology department and got involved with a professor there, did research with the professor, and I just got hooked. I got totally hooked, and realized once I was in graduate work, my issues were coming up inside that work. So then I really got hooked because I was like, I need to be a patient and a therapist at the same time and make sure that if I'm going to go into that room, I'm going to have a balance of lived experience, but also the clinical knowledge too. So that's really what got me interested in being a therapist, but a specific kind of therapist, one that is not necessarily going to deny, painful past experience myself and disappointments with this structure that we have, the mental health experience and the mental health services, arena. I kind of had a dual purpose. I really want to help people, but I also want to change the whole idea, the concept of getting help, if that makes sense.
Yeah. Which leads us to the question about what do you feel keeps people from seeking therapy? What do you think is the hesitancy?
Well, I think the hesitancy is actually what keeps people in a way from getting help, because usually, like kind of like quitting smoking, you've thought about it a million times, maybe for like 10 years. And so by the time people are thinking about making that step, it's probably gotten pretty severe, whatever the it is. And I also think that because of some of the medical model that we operate under, a lot of people do not think, although things are changing, that it is going to be a relationship. It's still like a service, a treatment, and we still speak about it that way. So it's really hard, and many people have never had a real trusting, listening relationship. So they're like, is that really what it is? Is it just talking? So I think there's a lot of hesitancy because people are waiting so long that they're coming with big stuff, and they're thinking, is this going to be this is an evaluation? I don't want that with all this big stuff. So there's hesitancy on that level. And then I also think that there's like a painful past experience with sharing with whoever it was the first time that happened, and fear that is going to happen again. So almost like projecting what's happened to them already in the regard of being understood. That is just like, oh, that's going to happen again. That's going to happen again. Some type of philosophy of just like, you know what, it's probably better to just kind of cope with it on your own.
Got you. So what are some things you'd like people to really understand about what therapy is?
I want definitely for them to understand that it's a relationship.
Yeah.
With a real person, and who's going to grow from your experience too. I mean, I tell and it's always weird to say patient, because I don't think of my patients as patients. I think of them as people, but I don't want to call them clients, because that sometimes seems like, they could be like I'm a financial advisor.
Right, like business. At first, like a business relationship.
Right, right. But I want people to understand it really is it's about a relationship that is going to affect you on so many levels in a good way. You're going to leave sessions sometimes not feeling better, but feeling like you have something that is going to clean up so many things for you. It's going to trickle into work. It's going to trickle into your family, your friends. So I really want people to understand that you're going to come in thinking, oh, I just want to stop these panic attacks, or I just want to stop ruminating about this person that's been out of my life for years. But you're gonna grow on so many levels, because it's the healthiest relationship, hopefully, that you will ever have with another person, and then you're gonna take that and spread it into your life.
I love that you spread it into your life, kind of like seeds, like you're spreading in so that things will bloom.
Right, exactly.
And, it makes me think of, I know when I was a little kid and I happened to see my teachers out of the classroom, like in the grocery store, you forget that they're real people too. I think there's this idealization of therapists. So, in your opinion, why do you think people don't feel that therapists might be real people themselves?
Well, I think, in some ways you're, like I said before, you're going in at kind of the problem is the worst it's ever been, usually. And so you're about to kind of tell someone your story and have them reflect back what they heard. And if it's a regular person in your life, you don't usually want that. You maybe want to kind of complain a little bit or talk a little bit about your problem, but you're not usually ready to be like, hey, mom, this is my problem. So you kind of need to have that person just be a blank slate. And I think sometimes what can happen is you either project an ideal. So I want this therapist to be the ideal sister, the ideal mother, that whoever your ideal, or the vice versa can happen. It's so embedded in fear. Will this person understand me? That the therapist becomes your worst fear, that teacher that judged you, that parent that, abandoned you. So I think that you come in with baggage from past relationships, and it's not conscious that people so say to themselves, oh, I'm not going to think of the therapist as a real person, but it's just all these other relationships paced over. And because that can be really intense, and usually people are really smart about their stuff once they start talking about it, so they can feel it too. And they'll, I get some, what one might consider as inconsiderate behavior is so not in the context of a session, because you can see that they just need you to just not judge them. Mm-hmm. And we as therapists, we participate in that because we're like, I'm here to help, whatever you need, project on me. It'll be good. It'll be good for the relationship. We'll figure it out. So we participate in that a little bit as well. And our own kind of, I want to help you through this, squashes a lot of what we would normally maybe push back on a little bit and say, hey, I am a real person, if that makes sense. Mm-hmm. So I think it's a tango. We also say, we're not real. Don't worry about it. Do whatever you need. This is safe space. But also people just need that because of most pain points are about other relationships, and they kind of paste them onto you a little bit. Right.
That projection on therapists, for sure. Yeah. So what are some things you would like for people to understand about therapists?
About therapists?
Yeah.
I mean, honestly, becoming a therapist, and I think this is really true for most people, it split me wide open. It's made me who I am. Mm-hmm. So I really believe in the process, but that's not to say the process is going to be the same for every person. So while some people think that, you go to the doctor and you just go through the same thing. You're, take a number, you could be anybody's name. When we say that you have a treatment plan, I mean, you really have a treatment plan. Because of the medical model, sometimes on paper, it looks like, generic words, but each therapist is, we're definitely thinking about you more than you're thinking about us between sessions.
Yeah.
And so we are developing a really intimate relationship with you in our heads. And that's not, I think in the past, therapists don't talk about that because countertransference is bad. Right. Boundaries are so important, but to deny that is kind of, I think at this point, especially since the pandemic, is kind of ridiculous. We are thinking about you all the time. And when you leave a session and we realize that we missed like an opportunity or something, like, oh my God, that going like this wasn't really going like this. It was like literally almost like, I don't want to talk about this anymore.
Right.
You miss that opportunity. And we think about that. We ruminate on it. Another thing I want people to know is you sometimes are helping us change and helping us be better people. Your experiences might be an experience that we've just never fathomed before, or about panic attacks, but when you see, somebody coming in who's recovered from panic attacks and now they're coming back, it's like, oh my God, that is such a painful experience that you can't just put on a sheet that says diagnosis panic attacks. It's like, no, recovered from panic attacks, now coming back. They're coming back. That's a totally different diagnosis in a way, but that you can't just, put on the DSM. So I think that, people should really know, we are monsters at understanding you. We do not want to just slap a diagnosis on you. We do not just want the 45 minutes to be up and next person. We do not just get concerned about your copay or, I'm sorry, I'm not going to take you if we don't accept your insurance. That is what we suffer from for this work, but that is not something that we participate with. It's what comes to us that we have to accept in doing this job.
Right. I think you bring up a great point, excuse me, of how, we do think about our people between our patients, our clients in between sessions. And then I think another thing that people don't understand about therapists is that our patients, our clients can also have an effect on us in various ways.
Yeah.
There's things like burnout and compassion fatigue and vicarious trauma. And so I thought this would be a great time for us to kind of dig in a little bit and have you help us understand kind of those terms a little bit more.
So, what I'm realizing is these words get thrown around like they're the same thing.
Yeah.
And there's a lot of history behind, we've discovered these phenomenons. And then in our field, the struggle is always, how do we study? How do we quantify? How do we make a set of criteria for if this is occurring? Burnout is well known in any situation. I mean, any role that you can have in life, you can get burned out from being a mom, but also a, Metro North worker, a car salesman, a therapist. So, I think of it as like a spectrum. Burnout is really when you're getting exhausted from the job and you're coming home and you can't function, but not a total deterioration of function, but it's more like, you sit at dinner and you can't participate as much with your kids. You're a little bit frazzled. You want to have that healthy routine and wake up early and go for a walk in the morning, but you can't do it. So you're kind of like fatigued from the work itself. Yeah. When it gets to, and I'm kind of imagining it on like a gradient, when it starts to move into compassion fatigue, it's more like you are starting to think, I don't know if I'm helping enough. I don't know if I'm doing a good enough job. I don't know if I can in this structure. So with insurance the way it is, or only a certain number of visits, or, telehealth not being for everybody. And you're really starting to feel like overwhelmed by your capacity to help being diminished somehow. And then there's like a little uptick on compassion fatigue when you start to get almost like depressed by the person's stuff themselves, or you just feel like their problem, it can only be managed so much. And you may be starting to work harder than your patients are. Okay. When it starts to get into compassion fatigue, when you feel like no one's doing their work, and I keep trying to think on like, how do I get them there? And you're a little bit, I don't want to say broken, but you're kind of you're not feeling effective. And
that's a good word. Good description of
it. And you're feeling isolated, more important. You're not thinking about getting supervision. You're feeling like no one would understand. You're feeling like, should I continue doing this? What's the longevity of my career? And that's when compassion fatigue is really starting to kind of take its hold. When it gets into vicarious trauma, I mean, there's different ways clinicians are clinicians. So there's a way you can have vicarious trauma when you do actual trauma work. And there's definitely various ways a clinician can be involved in trauma work, front lines, aftermath. But I'm going to talk about it in the more general sense, is when you have vicarious trauma and you're really thinking like these experiences that are happening to people out in the world are like happening to me too. Yeah. And I'm not going to recover. I'm not going to be able to do this work anymore. This was, maybe there's people I have damaged, and you're really starting to almost have like your own traumatic reaction. I almost hit compassion fatigue early in my career. I mean, vicarious trauma early in my career, when I had to start as a peer specialist.
Okay.
So they had me being a therapist sometimes I was a group therapist, sometimes I was peer, sometimes I was a crisis responder. And the boundaries were so blurred that I started to just feel like, what did I just do? I can't do this. I'm just starting out. I haven't even been licensed yet. And I really don't think I can do this. What's going to happen to me? I was really like not sleeping. When people would tell me their issues, I was just getting like, I was wearing the issue on me. So I think that when I say it's like a gradient or a spectrum, I feel like in the field we're headed towards, we need to, as systems, teach systems how to identify this in all professions.
Yeah.
Also, I think we need to teach clinicians, like, this is happening to you actually in every session. You're getting a little bit of compassion fatigue, but you're managing it. It's how do you accept that you're always having countertransference, compassion fatigue, burnout, and you're just treating it. You're developing a set of tools, and it's not, you come back. You come back and you have resilience, and your clients or your patients are doing well. But there are times, I think, when we really need to be knowing you got to diagnose yourself, and that you are on the spectrum. You're on the spectrum all the time. You're never not on the spectrum.
Right.
I think that's really, really important, because there's still that nugget in actually, there's still like a huge chasm in our field where it's like, if you're really good, you're always like, yeah, I love this work. Like all my patients love me. And I definitely was trapped in that for a long time. When I came from a hospital setting to Lifestance, a lot of my clients followed me. And I was like, yeah, I'm so good. And the reality is, some of those patients shouldn't have followed me to the more independent outpatient setting, because they were severely, they needed to be connected to the hospital setting where they could go, up into inpatient if they needed to after one of our sessions, or into the outpatient program after they had one of our sessions. So early on, I definitely was kind of, I'm a monster at this. Like, I'm never going to back down. I'm never going to give up on one of my patients. And it was patients themselves that kind of are observational, and they start asking you, like, are you okay? That, really kind of made me realize they try and address it in grad school. You need self-care. But I think it's not so much that you need self-care. You need to be constantly growing as a person.
Yeah.
You need to be constantly recognizing that you're not being perfect is exactly why you're perfect for this. Your acceptance of not being perfect is exactly why you're so perfect, because you will realize you're having, a session with someone and they're talking about their spouse, and you're like, oh my God, that's why I'm not, focused this week, because I've been dealing with a similar thing, and I've been just saying, I'm a therapist, everything's fine. It's more about my patients. I need to, make sure that that's wrapped up in a box, so that I can be there for my patients. So I think it's just really, really important that we recognize it's always happening.
Yeah.
This is happening, and you have to recognize that you should probably be every week kind of diagnosing where you are.
Kind of assessing your own well-being.
Yeah, exactly. And then I also think, something, that probably our higher ups are not going to appreciate, but email your higher ups and let them know when we're not having trauma-informed treatment. I think Despina here, and a little bit Anne and Siobhan will know. I don't think, we don't have anything in the patient consent that says you kind of can't just drop out of treatment. You're going to have to, if you want to stop, you're going to be called and asked for a termination session, because we're not going to just let you walk away and make sure you don't have some type of plan or somebody helping you, no judgment. We're not trying to get you back in, but that can be traumatic, to just, your insurance bill got too high and you're just going to stop treatment. Like, no, we don't have to charge you, but talk to us about, what your plan is, even if you're going to make that decision. So I think also too, as clinicians, if you're ever feeling like you're possibly overworking to try and solve a systems issue, email your higher ups and say, listen, I'd really like to talk to somebody. I don't know exactly what I'm thinking, but I'm thinking something in this area. When they are just sent a bill and then we don't see them, like, that needs follow-up. And me as a clinician, it's a little bit larger than what I can do to have some type of thing to address that, maybe even in a preventative way, and not wait till after it's already
being proactive about it.
Yeah.
Any other takeaways you'd like to share?
Yes, I think that it's just really, really important, I think, for people out there to realize this is all about you. And if you are better, everybody is better. And I know that sounds so cliche, but the getting help is truly helping everybody. You will find that once you have, even if you just come in and you're only solving a minor issue, you will see that it impacts the rest of your relationships.
Mm-hmm.
And I also want to say, shop around. If you go to a therapy session and the dynamics, you don't click with the person, I'm not lying when I say it's about the relationship.
Yeah.
So what you would do, and I think clinicians should feel more comfortable too, to say, you know what, I felt like you were holding back. Do you think that you want to try another intake with another clinician, or was there any type of thing that you were expecting today that you didn't get? Because I'm feeling like maybe you're a little unsatisfied right now.
Mm-hmm.
And I think that we should, as clinicians, be reminding ourselves that, like, okay, but you're kind of in also a real relationship right now with someone, and they're having you. All of us as clinicians, I think, could be a little less scared that they're out there Googling us and trying to realize like who we are as a person. So wouldn't you rather tell them the
right
identity of who you are than try and kind of pretend that what they're seeing or what they're looking up is real information, or superimposing what they see on TV.
Right.
I was talking with my brother because he used to be a trainer for like more the corporate world and helping managers. And we were talking about how sometimes you're late. Sometimes people are back to back and it spills over. And I say to him, sometimes I'm literally starting a session like a goofball because I'm just like, I'm so sorry I'm late. There's really no excuse for it. I'm not going to tell you the story unless you want me to, and I'll start session like that because they start session like that too. And I think sometimes it's important for them to see what that looks like when they do it to you.
Yeah. Gosh.
I always try and bring little nuggets of like what happens in real relationships in session.
Yeah, no, I think that's great. And you exude such a caring, sensitive nature. I can see where your own individuals that you work with probably definitely feel that. You're very genuine, which is, I think, so key to being a good therapist as well, that genuosity of it too.
Yeah. Well, and I think that's why it's important. I mean, it's not for every clinician. And if you have, very like kind of strict CBT, approach. But I do think doses of genuineness can be built in, and it's not going, the take home message, I think, for clinicians is it's not going to hurt. You are not starting to become some blurred person who's talking about their divorce in the other person's session. So I think it's really important to, if you have not tried, at least to hone that craft of bringing some of the real you into session, try it, and go back to your grad school days. We had to try stuff. You were not perfect when you were first starting out. So trying something new now is not going to hurt you. It's only going to make it better. But you do also not have to be in isolation when you're trying these things. You want to talk about if you tried something new in a session and you feel like ridiculous because you were stumbling and it didn't go well, and did you harm your client or your patient or the individual, talk about it, definitely talk about it. And just, I want people in the world to know that we're growing as people, but I really want give clinicians the permission.
Yeah. Yeah, I think that's key for ourselves, giving ourselves permission to grow as people.
Yeah, definitely. And, I think there's a little curiosity out there, like, have all therapists been through stuff? And I can't really speak to that, but I know I have. And it's not that becoming a therapist is my solution to that. Definitely not. But I have been disappointed by therapy. The certain traumas were not identified. No one, kind of brought it out of me. But that's why it's so important that people understand it's a relationship, because you have to be sure that you're going to trust this person, and then you bring it out together. It's not.
I love that, bringing it out together.
The clinician kind of goes like, I went to the therapy session and she didn't even pick up on that. And it's like, well, because you have to wait for the trust, and you're going to trust yourself to reveal more information, tell your story in a different way each session, even though you think you're talking about the same thing. And once the clinician starts to really know you, they're like, wait a minute, I think you're holding back there.
Right.
Wait a minute, why was that language all of a sudden like a younger you? I got a vibe that you were like a younger you all of a sudden. And then it opens as it should. Everybody's had that feeling of when a relationship gets deeper and you're like, oh my God, this is so cool. I know so much more about you. Well, therapists feel that way too.
Yeah.
Get to know more. We're like, now we can really kind of get you past your pain points or help you understand what's happened to you in your life, and who you are right now, sitting here talking about this particular problem at this particular time, So you can see, like, as I get really into it, I get so animated.
I can see.
I'm so proud of people working on themselves, and it's just so good for the world we're in right now.
I can see your passion with all this too, Melinda. You definitely sound like you being a therapist was your calling.
Yeah. So I like to say, I know we're probably like winding down. I like to say that so in the pandemic, because I don't have as much contact, or I didn't have as much contact with my colleagues, I was writing a lot. And I realized one day, I'm like, I call it my by accident book, because I started by accident writing a book. And I think I'm going to call it Therapists Are People Too, in the hopes that therapists can see a way that they can kind of work on themselves, but also bring it into session, but in the working on themselves, take care of themselves too. And then people can get a real understanding that, we are in therapy too with you. When you're doing the work, we're kind of doing the work too. And that we really are rooting for you. We want you to, work on what you need to work on, and then maybe stop working on it and come back again if something else comes up. I don't want to minimize that. Yes, we have a DSM and diagnosis is important. And some symptoms are symptoms. And it's, like when we did the podcast for bipolar, you're not a bad person because you're in mania, and there's not a better way to think about your mania. But also too, if you address yourself as a person and what's happened to you in your life, and you're just healthy with all those painful points that never got processed, actual symptoms, if you have panic attacks, if you have mania, if you have deep depressions, will actually improve. Because when you feel better, when you feel healthier with your relationship with yourself and your thinking, you think about other people better, and that actually changes your chemical makeup. So, I could go on and on and on about how wonderful therapy is for the whole world. But I do really think it's about, trust that for clinicians, trust that you are having about 1 million relationships a year. So take care of yourself, because you're not just providing a service, you're in like multiple intimate relationships. And for people, trust that this is a real relationship. So when you start building the trust, don't get scared. Don't drop out of treatment. Keep going. It's going to be wonderful for you and all your different systems that you participate in, your family, your friends, your work, your community. And kind of like, like the pandemic has shown us, kind of almost like politically at large, we become all of the same viewpoint because we're all just wanting to be better humans,
Exactly. Thank you, Melinda. Again, your dedication, your genuineness, your passion all comes through. And I wish you well on your book too. I think that's a great idea.
I said it now. I said it out loud. So now it has to
out there.
Kind of the trick. I needed to say it out loud so I actually finish it one day.
Right. No, best of luck with that. And thank you again for being on and sharing your knowledge on this.
Thank you for the opportunity, Nikki, and all your ways that you're offering opportunities to so many of our clinicians, feeling like they have a voice in their whatever their speciality is. No. Thank you so much.
You're welcome. Convos from the Couch is produced by the amazing team of Jason Clayton, Chris Kelman, and Juliana Whedon. Please subscribe to Convos from the Couch on Google, Apple, Spotify, or from your favorite podcast platform. Thank you for listening.